If you want to heal a torn tendon, the worst thing you can actually do is give the body all the medicine at once.
Right, which sounds completely backwards.
It really does.
Yeah.
I mean, imagine you're walking into a clinic for a cutting-edge regenerative treatment. Maybe you're dealing with a bad knee that keeps you from running, or a torn Achilles, or even thinning hair that you finally want to address.
Yeah, you just want to get it fixed and get back to your life.
Exactly. You're sitting there on the exam table, you want a quick fix, and the doctor hands you a schedule. And it doesn't just cover today. It spans months. Like 3 sessions here, a 4-week break there.
A follow-up half a year later.
Yeah. It can feel incredibly confusing for you as a patient. Like, why are we waiting so long?
Well, it feels counterintuitive, mostly because, we're so conditioned by modern medicine to expect these immediate acute interventions.
Right. Take a pill, headache goes away.
Exactly. Or you get a steroid injection in a swollen joint, and the inflammation just visibly drops by tomorrow morning. But regenerative medicine operates on a completely different biological paradigm.
You're not just masking the pain.
No, not at all. You're not suppressing a symptom. You are attempting to rebuild tissue from scratch.
Which means the timeline completely shifts. And that is the exact mission of our deep dive today. We are going to decode the precise timeline and spacing of regenerative treatments.
It's a great topic.
We've pulled together a really fascinating stack of sources for you. We're looking at medical textbooks on prolotherapy, the latest clinical practice guidelines from the American Academy of Orthopedic Surgeons.
Some really heavy-hitting stuff in there.
Yeah, and some deep dive research articles into platelet-rich plasma, extracorporeal shockwave therapy, and exosomes. We basically want to know why the magic number for chronic indications is so often, 2 to 3 sessions spaced 4 to 6 weeks apart.
Because that spacing is everywhere in the literature.
Right, and what actually happens at a cellular level when we deviate from that schedule.
Well, in this field, the timing is genuinely just as important as the treatment itself. We aren't temporarily numbing a nerve just to get you through a tennis match.
Right.
We are trying to fundamentally hack the body's biological clock. And if you fail to respect the rhythm of that specific clock, you are, quite frankly, just wasting your time and your money.
Okay, let's unpack this, because before we can even begin to understand the calendar of these treatments, we have to understand the clockwork of the human body.
Absolutely.
So here's my foundational question. Why can't a patient just walk in, get one massive high-dose injection of PRP or prolotherapy, and just be done with it?
Like a one-and-done kind of thing?
Yeah. Why not just flood the zone, give the body all the growth factors it could ever possibly need on day one, and just go home?
To answer that, we really have to look at what the medical textbooks in our sources call the wound healing cascade.
Okay.
Healing is never a single, isolated event, right? It happens in very specific, overlapping phases. Think of it as a tightly choreographed sequence.
Like steps in a recipe.
Exactly. First, you have hemostasis, which is just the immediate clotting of blood to stop the bleeding. Then comes the inflammatory phase, where the body sends in white blood cells to clear out dead tissue and bacteria.
Which is where the swelling and pain come from.
Right. That is followed by proliferation, where the actual new tissue is built. And then finally, remodeling, where that fresh, disorganized new tissue is strengthened and aligned so it can handle physical stress.
So it's essentially like building a house. You can't put up the drywall before the framing is done.
That's a perfect way to visualize it.
The framing is your proliferation phase, and the drywall is the remodeling.
Yes. But the problem with chronic pain like, say, severe knee osteoarthritis or a tendon that's been aching for over a year is that the project has stalled.
Oh, the construction just stopped.
Precisely. Those injuries are often trapped in the inflammatory stage. It's as if the demolition crew came in, tore up the site, and then the framing crew just never showed up.
Wow.
The local repair cells get used up, and there's a critical lack of chemical signals, specifically growth factors, to push the process forward into the proliferation phase.
So the goal of a regenerative injection isn't just to drop off a pile of raw materials.
Right. It's to deliberately restart this stalled cascade from the very beginning.
And the sources highlight something really critical here. A 6-week window of opportunity following an injury to soft tissues and joints for maximum healing.
That window is huge.
Because once that window passes, if the tissue hasn't moved through those phases properly, the body essentially gives up.
Yeah.
You might be looking at permanent structural impairment without some kind of regenerative intervention to wake the system back up.
Which is exactly why we have to trigger that inflammatory response again. We are functionally tricking the body into thinking there is a brand new, fresh injury.
Just ringing the alarm bells again.
Yep.
That alarm bell forces the nervous system to send new growth factors and stem cells to an area it had previously just abandoned.
But let me push back on this a bit.
Sure.
If we inject someone and the body finally starts trying to heal, like the alarm bells are ringing, the framing crew has arrived, aren't we actively interrupting that exact healing process if we inject them again 4 weeks later?
That's a very common question.
I mean, if the body's already doing the work, why not just let it run its course entirely? Like with farming, you can't just dump a year's worth of water on a seed on day 1 and expect a tree tomorrow, but you also don't dig up the seed a month later.
No, you don't. But this comes down to the concept of boosters and the natural half-life of these cellular signal.
Okay, so the signals fade.
Exactly. The therapeutic effects of something like a platelet-rich plasma injection, which is heavily concentrated with your own growth factors,
Yeah.
actually peak within the first few weeks.
Oh, I see. After that initial surge, the cellular signaling starts to diminish. If we just leave it alone after one shot, a stubborn, chronically degenerated tendon might just stall out again before the proliferation phase is complete.
So the body basically runs out of gas before the house is completely built.
Precisely. By timing a second or third dose 4 to 6 weeks later, you are sustaining that cellular momentum.
You're topping up the gas tank.
Right. You're providing a fresh wave of platelets and growth factors just as the previous wave is naturally starting to wane. It keeps the proliferation phase going strong without overwhelming the surrounding healthy tissue all at once.
So you're pacing the inputs to match the body's physical capacity to actually synthesize new tissue.
Exactly.
So now that we understand the biological necessity of pacing, let's look at the classic timeline for the most common regenerative injectables you might see in a clinic.
Good idea.
Let's start with prolotherapy. The textbooks define this as using hypertonic dextrose, which is basically a highly concentrated sugar water solution.
The mechanism here is so fascinating. When you inject that strong sugar water into a damaged ligament or tendon, it creates a hypertonic environment.
Okay, what does that actually mean for the cells?
Well, through the simple process of osmosis, that heavy concentration of sugar actually draws water out of the surrounding local cells. This causes those cells to temporarily shrink and undergo a mild, controlled microdamage.
Wait, so the sugar isn't feeding the tissue, it's deliberately dehydrating it to cause irritation.
Exactly. That controlled irritation is what summons the inflammatory demolition crew back to the site.
Wow.
And once the inflammation starts, it wakes up the fibroblasts. Fibroblasts are the body's microscopic construction workers. They are the specific cells responsible for synthesizing new collagen fibers.
And according to the textbook sources, the standard course for this is usually 4 to 6 treatments, spaced 3 to 4 weeks apart.
Because you have to wait for that dextrose to dehydrate the cells, initiate the injury response, activate the inflammatory cascade, and then give those fibroblasts adequate time to lay down the initial layers of new collagen.
You can't rush them.
No. If you inject again after only a week, you're dehydrating and damaging the exact cells that are trying to lay down the new tissue.
Which brings us to PRP, platelet-rich plasma. This is the treatment where they draw your blood, spin it down in a centrifuge to concentrate the platelets, and inject it back in.
Right, the vampire treatments, as some people call them.
Yeah. And the spacing seems similar to prolotherapy, but maybe slightly more refined depending on the specific injury.
The clinical data for PRP is incredibly robust now. For instance, the research on Achilles tendon issues shows that 3 injections spaced 2 to 4 weeks apart is the absolute sweet spot.
2 to 4 weeks.
Yeah, that specific interval maximizes the concentration of platelets and bioactive factors right at the site of the injury, ensuring the repair cycle stays active without prematurely triggering a secondary inflammatory response that might break down the new collagen.
It gets even more precise when we look at joint degeneration. Like, we have a longitudinal study in the sources looking at knee osteoarthritis.
That's a great study.
They categorized patients by how severe their arthritis was using the KL grading system. KL grades 1 and 2 are your mild to moderate arthritis. Maybe some narrowing of the joint space, minor bone spurs.
Right.
For those patients, they hit their maximum pain relief and functional improvement after exactly 4 monthly injections.
But for the patients with severe end-stage arthritis KL grades 3 and 4, the timeline stretches out.
Because there's more damage.
Exactly. A grade 4 knee is functionally bone-on-bone. The cartilage matrix is severely degraded. Those patients required up to 5 treatments spaced a month apart to see optimal results.
So the dosage and the timeline physically scale with the depth of the tissue damage.
They do. But what is highly critical for you to understand as a patient is that the study noted a definitive plateau effect.
Meaning more isn't always better.
Right. Doing a 6th or 7th monthly injection didn't offer any statistically significant additional benefit. The cells in your joint have a finite number of receptors for these growth factors, and eventually those receptors just max out. The optimal number really hovers around that 3 to 5 range, spaced about a month apart.
See, here's where it gets really interesting. I hit a wall when I was reading through the prolotherapy data.
Oh, yeah.
Everything we just established about waiting 4 weeks for the inflammation to do its job is completely contradicted by a newer type of prolotherapy called PDRN, or polydeoxyribonucleotide.
Oh, PDRN. Yeah, that protocol completely flips the traditional script on its head.
It really does. The sources state that traditional dextrose prolotherapy can take anywhere from 9 to 20 weeks to complete because it heavily relies on triggering that osmotic damage and subsequent inflammatory phase.
Right.
But with PDRN, the injections are done weekly for just 3 to 5 weeks. Why is this one specific injectable suddenly allowed to break all the spacing rules?
Well, if we connect this to the bigger picture, we have to look at the altered mechanism of action. PDRN is fundamentally different from dextrose. It's actually composed of highly purified DNA fragments extracted from salmon sperm, surprisingly enough.
Wait, really? Salmon sperm?
Yes, actually. And these specific DNA fragments bind to some receptors in the body that directly promote cellular proliferation.
So it tells the body to start building tissue directly without the damage.
Yes. But more importantly, it does this without causing an inflammatory phase. It skips the demolition crew entirely and goes straight to the framing crew.
It bypasses the very first step of the healing cascade.
Completely. Because PDRN doesn't cause that initial inflammatory flare-up or cellular dehydration, you don't have to wait 3 to 4 weeks for the inflammation to subside before you give the next dose.
Oh, that makes so much sense.
In traditional treatments, inflammation is the biological bottleneck. It's necessary, but it is slow. If you utilize a biologic that removes the bottleneck, you can drastically compress the treatment timeline.
So it completely eliminates that post-injection pain flare-up that patients usually get with dextrose or PRP.
Exactly.
The 4-week wait isn't just an arbitrary medical rule. It's a direct reflection of the specific biological pathway we are choosing to activate. Change the pathway, and you completely change the clock.
That is the core principle of regenerative medicine.
Okay, so we've been talking entirely about chemical liquids tricking the body into healing. But is there a way to force this same vascular healing without injecting anything at all?
Moving to the physical side.
Right. What happens when we switch from biology to physics? Let's look at extracorporeal shockwave therapy, or ESWT.
This is a vital part of the regenerative toolkit, especially for chronic tendon issues. Instead of a needle, you're using high-energy acoustic waves to physically stimulate the tissue from the outside.
For conditions like plantar fasciitis in the foot, or tennis elbow, calcific rotator cuff, tendinopathy, things like that.
Right.
The guidelines for ESWT present a completely different calendar than PRP. The standard protocol here is distinctly faster. 3 to 6 sessions, spaced exactly 1 week or roughly 5 to 10 days apart.
It's very fast compared to injections.
And there's a highly specific dosage too, like almost 90% of the clinical trials use exactly 2,000 impulses per session.
It is a very rigidly standardized mechanical dose across the literature.
But here is my pushback. Why are we suddenly doing this weekly? If we just established that collagen remodeling and tissue repair take weeks or even months to lay down the scaffolding, why are we hammering that same fragile tendon with 2,000 high-energy acoustic shock waves every 7 days?
It sounds aggressive, doesn't it?
Yeah. Isn't that violating the rule of letting the tissue rest?
Well, what's fascinating here is the difference in the underlying cellular response to mechanical force versus a chemical injection.
Okay.
As the acoustic waves pass through the tissue, they create microscopic bubbles, a process called cavitation. And when these microbubbles collapse, they exert physical stress on the cells. It's a controlled physical microtrauma.
So it's microscopic shock waves.
Exactly. The sources include a really compelling study by Takahashi and colleagues that looked at exactly what happens to the nerves and blood vessels under the specific physical stimulus.
And what did the Takahashi study reveal about that weekly timing?
They found that repeated shockwave application actually delays nerve remodeling in the short term.
Delays it.
Yes. By repeatedly stressing the nerve endings every once, you temporarily inhibit their ability to transmit pain signals, which creates a prolonged analgesic effect.
Oh, so the weekly spacing actively suppresses the pain while the tissue works.
Right. But the more crucial aspect is the vascular response.
How the blood flow changes.
Exactly. The physical stress of the collapsing cavitation bubbles triggers a process called neovascularization, which is just the sprouting of microscopic new blood vessels in tissue that previously had very poor blood supply, like a chronic Achilles tendon.
Which notorious for poor blood flow.
Right. The sources indicate that a one-week interval gives the tissue just enough time to begin sprouting these fragile new vessels. If you hit it again exactly a week later, that next wave of mechanical stimulation amplifies that exact same growth process before it can stall out.
So with PRP, we're waiting 4 weeks for chemical growth factors to be absorbed and processed. With shockwave, we're hitting a physical rhythm.
Yes.
We're essentially doing mechanical landscaping every 7 days to force the blood vessels to keep expanding their network.
And the research confirms that 2,000 impulses is the exact threshold required for that landscaping. In vitro studies on cells similar to the plantar fascia showed that 2,000 impulses produce significantly greater capillary proliferation than, say, 1,000 or 1,500 impulses.
Wow, it's that specific.
It is. It provides the exact amount of mechanical stress needed to optimize the weekly growth cycle without crossing the line into destructive tissue damage.
Okay, so we've gone from a 4-week wait with PRP to a 1-week wait with shockwave therapy. Now, I want to jump to the newest, most potent biologics discussed in our stack of research, exosomes.
Ah, exosomes.
Because here, the timeline stretches out so drastically that it honestly blew my mind.
Exosomes are currently at the absolute frontier of regenerative medicine, particularly in the fields of aesthetics and hair restoration. And their biological protocols are very distinct from standard blood products.
So let's look at the skin first. The sources detail microneedling with exosomes for skin rejuvenation, treating fine lines, deep acne scars, overall texture. The standard rule there is 3 to 4 sessions, spaced 4 to 6 weeks apart. So we're back to that monthly spacing. Why the return to the 4-week rule?
Well, it comes back to the intrinsic collagen cycle. When you microneedle, you create tiny physical channels in the skin. The exosomes are then applied, delivering concentrated cellular blueprints directly into the dermis.
Okay.
But the actual physical remodeling of the collagen matrix continues for 6 to 12 weeks after the treatment is applied. The sources clearly state that treating too frequently actually hinders the skin's regeneration.
Oh, you disrupt the scaffolding.
Exactly. You have to let the initial structural scaffolding be fully built before you send in the next construction crew to add more layers.
That makes perfect sense for the skin. But then we look at the clinical data for using exosomes to treat hair loss, and the guidelines mandate a massive prolonged wait.
Yes, they do.
They strongly recommend waiting at least 6 months before a second exosome treatment is applied to the scalp.
This raises an important question, and it actually trips up a lot of practitioners and patients who are so used to the monthly PRP schedules for hair restoration.
Yeah, I mean, if I'm a patient and I've just paid thousands of dollars out of pocket for an exosome treatment for my thinning hair, and you tell me I won't see you again for 6 months,
You're going to panic.
I'm going to be incredibly anxious that I just wasted my money. Is that massive biological wait time actually doing something, or is it just a waiting game to see if the hair eventually grows?
Right.
Like, how can exosomes be so incredibly effective that you only need them twice a year, while PRP for hair loss requires monthly hits for the first 3 months?
The anxiety is completely understandable, but the wait time is biologically necessary. It really comes down to potency and the nature of the inflammatory response.
Okay, unpack that for me.
Exosomes aren't whole cells. They are extracellular vesicles. They are pure, highly concentrated messenger packets containing mRNA and thousands of specific growth factors.
They're just the instructions.
Exactly. mRNA is basically the genetic instruction manual that tells your local cells exactly what proteins to manufacture. They are significantly more potent and concentrated cellular signals than what you get from spinning down a standard PRP blood draw.
So biologically speaking, the exosome instructions are just much louder.
Much louder and much longer lasting. Both PRP and exosome treatments trigger a controlled inflammatory response to initiate regeneration in the hair follicle. But because the exosome signal is so powerful, the subsequent regenerative response it triggers is prolonged over many months.
Wow.
If you inject a second round of exosomes too soon, say at the 4-week mark, you create massive overlapping inflammatory responses.
The signals end up clashing.
The sources explicitly warn against this. The overlapping inflammation causes the body's signals to clash, creating an environment that can actually shock and degrade the delicate hair follicles you are actively trying to save.
Which is the exact opposite of what you want.
Right. You have to let the scalp fully absorb and execute the exosome's vast set of mRNA instructions over a period of months before sending a new batch of blueprints.
So with exosomes for hair loss, doing less is biologically doing more.
Exactly.
It is a true test of patience. You're basically waiting half a year just to let the medicine finish its work.
And that prolonged metabolic activity is precisely why patients often see substantial, visible improvements in hair density after just a single session. The biology just needs time to translate those dense cellular signals into physical keratin growth.
So what does this all mean for you listening right now? If you take nothing else away from this deep dive, let it be this. Whether you're dealing with a bad knee, thinning hair, or persistent tennis elbow, regenerative medicine is not a magic wand.
Far from it.
It's a carefully timed biological negotiation. The treatment doesn't just happen on the day you sit on the exam table and get the injection or the shockwave.
No.
The real treatment happens in the dark, inside your cells, during all those seemingly quiet weeks when you feel like you're just sitting around waiting.
The waiting period truly is the treatment period.
You cannot rush the body's clock. You have to respect the standard series spacing, whether that's 3 sessions spaced 4 weeks apart to let the fibroblasts rebuild your knee, or waiting 6 full months for the mRNA to rebuild your hair follicles.
All about the timing.
But knowing all of this, what do you see coming next? Where does this field go from here as the science evolves?
Well, I want to leave you with a final thought to ponder regarding the future of all this. Right now, as we've discussed, we space these treatments based on clinical averages.
Right.
4 weeks for PRP, 1 week for shockwave, 6 months for hair exosomes. It's the schedule based on what works for the broad majority of people in clinical trials. But as medicine becomes hyper-personalized, we have to ask, what if future treatments could measure your exact individual cellular turnover rate in real time?
Oh, like a biological smartwatch, specifically tracking your internal healing rate.
Precisely. What if your perfect treatment interval isn't exactly 4 weeks? What if, based on your unique genetics, your metabolic rate, and your specific level of local tissue inflammation, your mathematically perfect interval is 23 days and 6 hours?
That would change everything.
It would. The next massive frontier of regenerative healing might not just be discovering new biologic substances to inject, but unlocking the diagnostic ability to match the exact, unique rhythm of your personal biological clock.
That is incredible. So the next time that doctor hands you a schedule spanning months, just remember, you aren't just looking at a calendar of appointments, you are looking at the exact biological time it takes to build a newer, stronger version of yourself from the cellular level up. Take the time, let the cells do their heavy lifting, and we will catch you on the next deep dive.